Now, there are so many things. 3D printing. I don't know if any of you have caught up on 3D printing, but it just triggered in my mind a thought about my uncle, who was actually born in Hawera, home of the biggest dairy factory in the world. He passed away only recently, but he was a great telephone collector and radio collector, and he was renowned as being the person who you'd go to get a part. And he was always specific about exactly how a screw matched what was the screw it was meant to be, and if he couldn't find the right screw, he'd manufacture his own on his lathe. And he's still doing that when he was 93. But it made me think in terms of 3D printing. The relevance of 3D printing in this conversation is perhaps not making the tractor, but it's making the part to replace a part on the tractor. You know, when something's broken and you need a part to replace it, you don't have to wait for it to come from somewhere far away. You can get it printed for you at the local 3D printing shop. That said, the other thing that we didn't really touch upon in the last session on rural was the significance, especially for rural communities, of a couple of the really big drivers that get mentioned every time anyone talks about broadband, and that is e-education and e-health. That is going to be the subject of our panel after lunch, but to get us started and to provide an overview of developments in that area, it's my very great pleasure to welcome Dr. Kate Cornick. Now, prior to being her current role, Kate was in fact employed by the same person who's currently employing me, Senator Stephen Conroy, and in that role she had a great role in the development of our broadband network plans, but since then she has gone on to become the Executive Director of the Institute for Broadband-Enabled Society. So I'd like you to welcome Dr. Kate Cornick.
Thanks, David, and it's a real pleasure to be here today. I have to begin by saying that I am neither an expert in e-education or e-health, but I do have the luxury of working with some really fantastic people who are doing some phenomenal work. And I'll come to what IBES does and our role a little bit later. As you know, I was asked to talk about e-health and e-education. I'm also going to stray into e-well-being because I think that impacts on all of us, no matter where we are in our life. To help me with this story, I hope you'll bear with me, I want to introduce Lucy. Lucy is, I will stress, a hypothetical child, I'm often asked that question, who was born in Ballarat, a regional town in the state of Victoria, Australia, last year in 2011. Like many children who are millennials, she's going to grow up in a world that is just embedded with technology. When I went to primary school in the 1980s, we had one computer in our school. Lucy will have smartphone, tablets, PCs, TVs at her fingertips. By the time she's 10 years old, she'll have used a vast array of tools and applications. When she was born, her parents probably won't give her a photo album of her childhood. Instead, she'll have a Facebook site, which will contain images of her childhood that she'll be able to access whenever she wants. She'll be used to reading e-books. The concept of hard copy books will probably be a bit foreign. She'll be used to Skyping with her grandparents in Queensland on a regular basis. She will have looked at a house on Google Earth. She'll have her own iTunes account or something similar. She'll be very used to tweeting, and as we've seen many people are today, she'll think email's a little bit old school, and she'll be perfectly adept at Googling whatever she wants. She'll be using online banking, as many of us do today, and probably will have spent many thousands of hours using video games. In fact, your average 16-year-old today in Western society will have spent about 6,000 hours doing computer games, and that's today. Some of those games have real benefit, like the active gaming technologies, Microsoft Kinect, that get people off their seats. But of course, they're the really useless applications like Angry Birds that just allow us to waste time away. Lucy will go to primary school in regional Ballarat, and her primary school will be embedded with technology. Her classroom will not be constrained by the walls of the physical building she's in. Her classroom will be the universe. She'll probably spend a bit of time telecommuting with other children around the world. This leads to some really interesting problems and something that we're working on at IBES today. What we do not want to see deployed is technology for technology's sake, and there's all manner of technologies that gets deployed in classrooms around the world just to ensure that there's technology in our classrooms. The reality is we need to be developing applications that actually mean that our children get the best possible outcomes. So that means addressing teaching pedagogy to make sure their learning in an ICT-enabled world is better than their learning in the real in the real world that we are very used to. So at IBES, we've developed this little application called Welcome Science One. It's got a few applications. And the idea is how can we pair up children in a regional town with primary school children in a metropolitan town? The reason for this is we actually just want our children in our regional areas to understand what it means to grow up in a metropolitan area, and our metropolitan children to understand what it means to grow up in a regional area. But how do you actually get two children to communicate online if they've never met each other and they don't know each other? Well, this system has been developed to ensure that we pair children in the right way. It might be that we pair them around a hobby, so they're introduced because they both know each other through, for example, they might like ponies, or they might like hockey or swimming, whatever it is. Or we compare them academically. We might choose to find a child in regional Australia that's really good at mathematics to help try and teach a child in metropolitan area who may be not quite so good at maths. We've been using the same system also at the secondary school level, with a school in Western Australia in Fitzroy Crossing, which has got a really high Indigenous community. At that school, they've got real issues with teacher staff shortages, particularly in areas like mathematics. So we're looking at how we compare students up in in very remote Australia with classrooms in metropolitan Australia, so that we can actually share resources. And we're also looking at using this system to connect school children in Australia with school children in Asia, for example, in Korea or Indonesia or China, wherever they might be learning about. It's one example of an application that Lucy might be used to using when she goes to primary school. Of course, there'll be many others. Some of them will be about research, and one of the applications that we developed at IBES last year was actually taking the Tasmanian convict records, which are UNESCO World Heritage listed, and putting them online. These convict records are really eloquently written in the 1800s and detail huge amounts of information about not only what our convicts did to turn up in Australia, whether it was stealing a loaf of bread or murdering someone, but also contains information about eye colour, length of limb, height, all sorts of interesting information, which are really valuable for historians, population health experts, and of course our primary school children who are learning about our history. But how can you actually put these records online in a way that people meaningfully can search them and interact with them? So we've been working with crowdsourcing with the University of Tasmania to help make these records more easily available to people across our community. And Lucy might use these to do a project in Australian history. When Lucy's 8 years old, she falls unwell. She'll end up at the Royal Melbourne Hospital like some 25,000 students every year. Unfortunately, Lucy ends up spending a bit of time in hospital, and this creates problems of its own. In fact, last year we were approached by the Royal Children's Hospital because they had an issue with social well-being with some of their long-term patients. The problem is that many children, in the orders of hundreds, end up in the hospital for really long periods of time. Really long periods of time, in fact. I met a little girl that had spent 6 months in hospital without going home because she had leukemia. And their longest staying patient to date is actually over 18 months, and that was a girl that was burnt in the Victorian bushfires. These poor children not only have to suffer their illness, but they also just suffer from a lack of connection to their communities. When they first go into hospital, their school friends might come and visit them and pay some attention, and the children feel like, even though they're unwell, they are still connecting back to their communities, whether it's in metropolitan Australia or regional Australia. But as time goes by, they get more and more disconnected from their extended family and their friends, and they also have a disconnection with their education system, and then they feel more socially isolated, which impacts on their well-being. So we were asked to develop a tool that would help with this situation. The problem is you can't just take technology and whack it in the hospital and whack it in the education system and say, here's a video conferencing call and you can go ahead and video conference whenever you like, because that disrupts the classroom and the child might not want to video conference anyway. So we designed this orb, and this little orb glows different colours. So Lucy has an orb in her hospital bedside, and it glows 3 different colours that she controls, and there's another orb in her classroom, sitting where she would normally sit. Lucy controls the colour of the orb, so if it's red, it means that she's actually unwell. She might be undergoing chemotherapy or may not be able to talk. If it's orange, it means that she's actually listening into what's going on in the classroom. She actually doesn't want to be looked at. She might not feel very well. She might be wearing her pyjamas and not want to be seen by her friends. But if it's green, it means that she's actually really keen to communicate with someone. So perhaps when playtime comes around, the school teacher can set up Skype and then Skype in, and all the kids in the classroom can actually connect with that child. We trialled this system at IBES last year, and it had a huge success and made a really big outcome to some children's lives that were having a really rough time. So Lucy recovers, thankfully, from her illness, and she goes to Melbourne, and she wanders down to Federation Square for the first time, a very big public space in Melbourne. And there's public screens in many places around the world. Melbourne and Federation Square is one such example. We're used to these screens pushing information out to the community, but as we move into a broadband-enabled world, there's all sorts of really innovative things that we can do around community building that also not only pushes information out to the people in the immediate vicinity, but pulls information from them that can then go around the world. So we've been looking at how we can connect people in squares across the world. And one of the areas that we're looking at is with the London Olympics later this year. How can we facilitate dialogue and communication that's active and interactive across the world using these big public screens? So Lucy experiences the public screen and has a great time in Melbourne, ends up going back to regional Ballarat, where she completes she continues her school education. Sadly, when she's 16 years old, she has a youth mental health episode. Like many children nowadays, her mental health is affected by depression. This is a really common issue, and we really need to rethink the way that we deal with some of these issues. When I was at high school, if we had a youth mental health issue, we were told to pick up the telephone to something like Lifeline. But the reality is, as millennials like Lucy won't be used to necessarily communicating with strangers over the phone. They'd be far happier using blogs or tweets or whatever it may be. But the question is, how do you monitor that information? Well, this is a really big issue for online mental health experts, and we've been working with a really prominent centre in Melbourne, the Origin Youth Mental Health Centre, to develop online tools that will help us monitor and support patients that are undergoing all sorts of different illnesses, from depression, schizophrenia, and first episode psychosis, but also show how that they can be used to support the carers, the clinicians, and their friends and family. The really important thing about this application is that we have to actually start treating different community groups, whether we're talking about particular health groups, education groups, community groups, whatever it is, as individuals. And in this case, we had to recognise that as someone who was suffering depression would have very different computer usage from someone who's suffering from psychosis. Someone who's suffering psychosis might have the feeling that there's a big brother out there. So how do we generate online tools that overcome those issues and really result in uptake and meaningful use, rather than just developing technology for technology's sake? Thankfully, Lucy continues through her school. She overcomes her youth mental health episode, and she decides she wants to become a doctor. So naturally, she chooses the University of Melbourne. I have to say that because they employ me. And she goes along to the university. Now, she doesn't choose to do an online course. Many people will do online courses in the future, but certainly at Melbourne University, we realise that the campus experience is really important to students. It's about meeting friends, meeting peers, having social life and all sorts of things. But one thing we already know today is that our students are juggling really packed lives. They have a really important social life, obviously, they're university students, but many of them also struggle with finances. So many of them are working at least part-time and some of them full-time. So the question of using and supporting online tools to supplement their education is really important. What we're doing with UniTV, which has been developed in partnership with Ericsson, is looking how we can translate the IPTV model that's been so familiar and used in entertainment systems into an education model. So we're not talking about over-the-top internet services such as Stanford and MIT are doing, where they're making all their coursework available. We're actually questioning, can we develop an online system that will really encourage our students to interact and have a much more meaningful experience? So UniTV is interactive. It displays lectures and all sorts of things like that, but it's also got video conferencing that we're building into it that enables students to interact, ask questions in their lectures, participate in tutorials, and collaborate with their peers on projects. It's an exciting project that actually is basically rethinking the university as a content provider in its own right. A really interesting question for education. So Lucy continues through her university degree, and she does all her usual lectures and tutorials and learns an awful lot about medicine. But then it comes to surgical training. And this was a real-life problem that we were approached with a couple of years ago at IBES. A cochlear ear surgeon came to us a little bit concerned about the level of skills that student surgeons are getting. The problem is that this skilled surgeon performs an operation and his students watch him perform that operation. He talks them through it and they look at it. They might look at it in a video. It might be something that they go back to already. These surgeries are videoed, as anyone who's seen the Alcatel-Lucent foyer out the back might have had the pleasure of watching an operation. But the problem is that the students are just watching. They're not actually feeling. So what happens is once the student has watched enough operations, they get to practice on a cadaver. There are limited numbers of cadavers for them to practice on. And then they actually go and get to practice on a real patient, and the skilled surgeon is obviously overseeing them. So what this surgeon was interested in doing was putting in an extra step. And what we've developed is a haptic device that emulates the cochlear ear surgery. Our goal with this device is basically is this machine here. And basically what it's doing is the surgeon is performing the operation in real life in the surgery unit. His students can take a device, whether they're at home or in a room next door, it doesn't matter, but they can actually feel exactly what that surgeon is doing as they're performing the operation. So they've got the visuals and they've got the feel of it. They can then go to the cadaver and it can be swapped around. So the trained surgeon can feel what the student's doing, and they can say, you're going too fast, or be careful of this artery, or whatever it is. So this is actually making teaching outcomes better. Our students, surgical students, may not just be learning by sight and sound, but they actually get to feel what's going on in a real-life operation. It means that our surgical students will be able to hone their fine motor neuron skills. And I have to say, I've had to demonstrate this device numerous occasions, including to our Prime Minister last year, and I've killed the patient every single time I've done it. There's a good reason why I chose engineering for a degree rather than medicine. So when Lucy's 21 years old at uni, she's having a great time learning to be a doctor. She decides to partake in horse riding and sadly falls off and has her teeth knocked out. That's the only relationship between Lucy and myself. It did actually happen to me. Certainly in my experience, I spent many hours at a dental surgery, travelling across town, waiting hours in dental surgeries. Then eventually, once I'd recovered and had a lot of treatment, basically going for checkups where I waited for half an hour in a waiting room, went to the dentist, 5-minute checkup, $100 later, he said, yep, come back in 6 months' time. It was an awful lot of time wasted in travel and ultimately a lot of infrastructure wasted at the dental surgery. So we've been developing a system which is doing teledentistry. The idea is a dental nurse could come to your home, your workplace, wherever, do an assessment and send live video footage back to a dentist. The dentist can then make that assessment, so you don't have to travel across town to visit him. And if you really need intervention, then you get brought into the surgery. Why are we doing this? The reason we're doing this is we were approached by an aged care facility that had a problem taking their patients to dentists. Dentist treatment actually relates to your digestion, and a lot of older people have problems with digestion. But the reality is when you've got older people that have got cardiac issues or respiratory issues, they're the surgeons and the clinicians that people need to go see. Dentistry is low down on the list, and when you're dealing with people that are mobility impaired, often have Alzheimer's or dementia, it's a really challenging task taking people to the dentist. So they actually wanted, their problem to us was, we only want to take people to the dentist who we know need to go to the dentist and have intervention, because we waste so much time and money transporting patients. And this was the solution that we've come up with, and we're working with this nursing home to deploy this solution. So you probably figured by now that Lucy has a fairly hefty medical record, and much like the share cared record that's been developed here in New Zealand, in Australia, the government has been driving the personally controlled electronic health record. And this has been driven by the National eHealth Transition Authority. At IBES, we've been developing our own personally controlled electronic health record that adheres to NETA standards for a particular group of people, and this is migrant refugees. These are people who are coming to Australia from often traumatic backgrounds, more often than not developing worlds, and they have complex and different disease issues than the majority of the Australian population. Diseases like tuberculosis and hepatitis C that mean that they have to have a lot of treatment plans over long periods of time. Set this against a backdrop whereby they're considered, regardless of whether they are or not, as unskilled migrants. They're often travelling around our countryside, going to orange picking season or helping in farm communities in the west, or going to the Yarra Valley to pick grapes, or coming back to the city when jobs are available. So they're highly transient. So we were approached by a group of clinicians who specialised in immunology to say that they wanted to develop a personally controlled health record for this group. So we've developed that health record, but it's far broader than just a health record. We're also working how can we do treatment plans and telemedicine with their GPs, so that's a much better treatment care program that involves a team of clinicians. Part of that team as well is interpreters, because many of the community don't speak good English. And also really other important part is having a community leader present in those discussions. Often some of the communities, particularly from Sudan, really struggle with Western medicine. It's something that's very foreign to them. So having a community leader that can put trust to help them to trust our clinicians to treat them properly has resulted in some really positive outcomes. So it's about bringing together all the people in the right room at the same time to develop a treatment program that's really going to mean a meaningful result. And we're certainly having some really interesting time developing this application, which is, as you can see up here, relatively in prototype form, but nevertheless is being rolled out at the moment. Another issue that Lucy might have encountered after a horse riding accident was physiotherapy. This device is a device that we've developed in our laboratory, and it's a haptic physiotherapy device. The idea is that you can undertake remote physiotherapy treatments. This device is an exercise machine, and it's basically looking at arm exercises. So you move your arm around, and the idea is the patient will have a machine in their house. This is a prototype machine. It would probably look a lot more attractive than this. And the physiotherapist would have the same device in their clinic. So the physiotherapist can actually feel what the patient is doing, whether they're in the room next door or across the other side of the country. If the patient isn't doing the exercise correctly, the clinician can take control of the machine and actually force the patient to do the right outcome. Perhaps the biggest benefit of this machine is the fact that it logs the exercises that have been done. So when the clinician asks the patient, have they actually been exercising, they can't lie because the machine's already told the clinician what's going on. So when Lucy's 28 years old, she buys her first house. Like many houses in the future, it will be digitally connected. It might have its own education service provider and health provider, but it will certainly have entertainment and probably meter management for gas, electricity, water, and the like. Her house will have a whole load of smart appliances, from refrigerators that tell her what food she needs to eat to dishwashers that turn on in the middle of the night when the electricity supply is cheapest. One of the things that I think are really important about this model is that this actually challenges the current retail service provider model in telecommunications. We can't be charging $40 a month, $50 a month, $60 a month on 2-year plans, whatever it is, if what you're transporting is a really small amount of data. If you want to be a smart grid company that's helping people more efficiently manage their electricity, you might actually be transporting really small amounts of data, but very often. But collectively, they don't add up to an awful lot over a month. So coming up with a data plan that is set for entertainment use is actually not going to drive an innovative market. So if you want to drive broadband, you actually also have to rethink the business models of how service provision comes about. Are we providing the opportunity for companies to come into the market that don't necessarily need a lot of bandwidth, whether that means instantaneously, for example, a health provider coming in to provide a one-off teleconsultation with a client, through to a smart meter manager that is going to monitor you with very small bits of bandwidth over a long period of time. So Lucy lives in her house, she's 29 years old, and something's missing. Like the 20 million people that visit online dating sites every month, she becomes another statistic. She eventually finds love, and she becomes one of the about 150,000 marriages that happen every year thanks to online dating. Her husband lives in the regional town of Shepparton, so she trudges off to Shepparton in northern Victoria and sets up a very successful general practice clinic where she's not only treating her local community, but she's treating people all around Australia and potentially overseas. The Australian government's doing a lot of work to support telehealth at the moment. They've set up the Medicare benefits scheme, which has been extended to telehealth at a cost of $350 million. This means that our GPs can actually start to charge and bill for teleconsultations. They've provided incentives to general practitioners, for example, providing one-off payments to allow them to acquire equipment that will support them doing telepresence. They're providing online training. And I think a really interesting and particularly useful initiative, the government's provided $50 million for our GP after-hours service, who can now do video consultation instead of coming to your home. Lucy's telemedicine might be in 2D, but it may also be in 3D. It's something we're really interested in at IBES because we've been approached by clinicians who have got an interest in 3D telemedicine as opposed to 2D. There's many sorts of medicine that are interested in this, but one particular example is wound management. Wound management experts that might be consulting into our regional hospitals rely on 2D images at the moment to make assessments, but that additional depth perception by 3D has got really interesting uses in medicine, and it obviously makes sense when you're dealing with things that do have depth perception like 3D wounds or perhaps overviewing operations or whatever it might be. Telepsychiatrists are also interested in 3D because the refined motor skills and really clear images of people and how they're talking and acting is really critical in that environment. Lucy will also be able to monitor her patients no matter where she is. This is a project that we've been developing at IBES, which is looking at online pollution monitoring. So rather than thinking of a particular area, it doesn't matter whether Lucy's in Shepparton or Melbourne, she'll be able to go online and find out the pollution statistics for Melbourne. But Melbourne isn't just one area. There's actually anomalies within that geographic area. So she'll really be able to pinpoint and better understand what's going on and why someone in the town of Dandenong might be suffering from asthma at a particular moment in time and be able to provide that advice. She'll have lots of tools at her fingertips that will help support her decision-making, as well as the patients themselves. So Lucy lives a very successful life. She has some children, and eventually she starts to age. Sadly, she starts to develop knee osteoarthritis, which, like many of us, is an issue that impacts on quality of life. Unfortunately, there's no real treatment for knee osteoarthritis except for knee replacements and things like that. But one thing that does happen if you've got really bad knee osteoarthritis is you get to go and see a specialist who straps a really big device to your leg and tells you to walk up and down a room normally so he can make an assessment of how you walk. The reality is this is not normal. What we were asked to do is develop some small sensors that people can our clinicians can strap onto patients' legs that can be worn throughout the day no matter where they are, whether they're in the supermarket, in the hospital or in their own home, and then they can collect data. This data is allowing our clinicians to better assess the patient as they go about their daily exercise and come up with better care treatment plans, which will hopefully result in more meaningful health outcomes in the long run. Sadly, when Lucy's 70 years old, she has a stroke. Sorry, just go back one. Sadly, when she's 70 years old, she has a stroke. Stroke costs Australia $2 billion per annum. There are currently 60,000 strokes in Australia, and for every 3 strokes that occur, 1 person will die, 1 person will survive with ongoing impairments that may affect their quality of life forever, and 1 person will thankfully survive. There is a class of drugs called thrombolysis that has allowed revolution in stroke treatment. Basically, thrombolysis drugs, if administered within 4 hours after a stroke, can actually reverse the impact of stroke. So they can take the people who could die or people who have ongoing impairment as a result of a stroke into a group that actually means full survival. We've been working with a stroke neurologist in Victoria who is really interested in using this for telemedicine. The reason he's interested in using this for telemedicine is that there are 22 neurologists in Victoria, and all of these are located within 50 kilometres of the CBD. If you live in Shepparton, which is many hundreds of kilometres from the city, driving 4 hours to get to Melbourne, you won't even get halfway there, let alone to a hospital to receive the drug. The sad reality is that 72% of hospitals in Australia are unable to treat acute stroke in the way that our metropolitan hospitals can. That's 72% of hospitals in Australia are unable to treat stroke. This isn't about broadband changing lives, this is about broadband saving lives, and I think this is by far our most successful project. We ran a trial last year with Professor Bernard Yan, the guy on the computer, who teleconsulted into Wangaratta Hospital, just one of our regional hospitals which were unable to provide stroke treatment. Over the course of a year, 153 people presented to that hospital with stroke. Many of them ended up receiving the drugs, and we categorically know we saved 8 lives. 8 lives of people who would have died got the drug that ultimately ended up in them having a happy and healthy life in regional Australia. I think this is one of the most powerful tools and one of the most powerful stories anyone can tell about broadband. And if people think broadband's just about education, I beg to differ. But the lowest hanging fruit of all has to be aged care. In Australia, 16% of our population is over to 65. This is set to double in the next 40 years. Currently today, there are 50,000 people in Victoria that are socially isolated. These are older people living on their own who do not have a sense of community or well-being, let alone whether their health is impacted or not. There are 175,000 aged care places in Australia, costing $9 billion per annum, accounting for 6.5% of the total healthcare expenditure. But a lot of this is not government funded, it's obviously privately funded. We have a really looming aged care crisis, and technology has a really important role to play there. What we're doing at IBES is actually focusing not so much on the monitoring of healthcare, but on the well-being. How can we help people maintain wellness into old age? How can we help them remain socially active and connected so that they are happier, therefore hopefully healthier, and have longer lives living in their own homes? One of the trials we did last year, we gave 20 very frail elderly people living on their own an iPad, and we connected that iPad to their grandchildren who had to be in the areas of sort of below 10, because after 10 it gets really uncool to talk to your grandparents. But we had these iPads distributed out. Our 20 participants, all when they started, thought that technology had no place in their life, and they did not see the point of having an iPad. 6 months later, when we had to ask for the iPads back, every single one of our participants complained. And we even had a letter of response from one of the children of our applicants saying that they had never spent $1,000 on their mother in their life, and now they had to buy her an iPad for Christmas. Technology changes lives, and technology in the aged care sector does not mean QWERTY keyboards. It means designing applications for our older people that are intuitive, and I think the iPad is a fantastic device that allows older people to engage with technology in a meaningful way and really quickly. The uptake and the understanding that our older people had in our study was that once they'd had a few-minute lesson in how to use an iPad, they'd worked their way around the application very easily, and they were also using it for all sorts of other things, including Google Earth and various things like that. Another area of work that we're doing in aged care is serious gaming, and I note that that was touched on an earlier panel. There's all sorts of applications around activity, and I think it's a really, really exciting area, active gaming and helping people stay in their home. Even if people are wheelchair-bound, exercises to help people lift their hands up and get a little bit of movement are going to help them stay healthier and for longer. But many people want to be supported in doing that, and online gaming gives them a way to do that. But one of the critical areas of aged care, which I think the ICT sector is really bad at doing, is certainly in Australia, is you design tools for the ICT sector for gaming, and then you adapt them for the aged care sector. We don't believe that is actually the way to proceed. If we're really going to tackle aged care, we have to start designing ICT devices and applications for the aged care sector alone, not adapt games that were designed for 18 to 25-year-olds and then expect our older people to take them up. But we do know that if we can design the right tools, uptake will become forthcoming. We've even got an application at IBES for death and dying. The application is looking at what does it mean if we live online to die online. And this all came about as a result of the Victorian bushfires. Unfortunately, a young teenage girl died in the bushfires and had a Facebook page, and it was what we called graffitied with some really rude words that are there for everybody to see. If you know the name of this child, you can go online and see what her so-called peers wrote about her. This isn't the way that we grieve people in the real world, so why should it be the way we grieve people in the online world? So we're designing applications to look at how we can support this into the future. So a little bit about IBES and who we are. Our mission is aligning, we always have, missions a bit gumpy, but aligning research and industry interests to drive innovation in broadband applications. It's certainly a really big feat that we've taken on, and I think some of the key learnings is that technologists love to design technology, but often they miss out the end users. And what we're trying to do is bring together multidisciplinary teams to make sure we're not technologists designing technology for the healthcare sector, but we're actually designing technology that we know the healthcare sector need before we start going down that process. And it means multidisciplinary collaborative teams. And the end user, whether it's someone in a stroke neurologist, a particular group of the community, an education institute or school, we have to treat people as individuals or groups as individuals. Technology is no longer a one-size-fits-all for everybody when you think about it in the sense of applications. The actual platform we use may be one-size-fits-all, but the application is, in most cases, not that way. We couldn't do what we do without the support of our partners. So IBES was set up as a joint initiative between the University of Melbourne and the Victorian State Government. And we also have huge support. We get about a third of our income from industry. Companies like Alcatel-Lucent, Cisco, Ericsson, Juniper, Microsoft all provide us access to their own R&D labs, access to their own technologies, and we get to leverage the exciting things that they're developing in their own laboratories, but we also get to develop things for our local environment in Australia rather than looking at worldwide solutions. So I think that collaborative sphere between multidisciplinary teams, but also the government, university and industry is a really important thing. My role is facilitating that. I can tell you one thing, it is really painful at times. One of the things that we've done last year is launch the Australian Broadband Applications Laboratory, which sounds fairly similar to the sorts of things that Alcatel-Lucent is looking at in New Zealand. The idea is that we're providing a hub for businesses to come in and innovate. We've got a replica broadband network that emulates the National Broadband Network Company, and the idea is that our technologists are there to support people to come in. We're not just providing a service to the ICT community. We're quite happy to listen to anyone that's got a bright idea. So it might be a health expert, an education expert that has no idea about technology, but if they come to us, we can help support them through that innovation cycle. And in our small way, we're making a difference to innovation in Australia. So, in summary, I guess this is summary / recommendations / what are our learnings at IBES, and they're certainly not comprehensive. But I think one of the really important points is understanding the drivers. What do our communities actually want, and are we talking to our communities? One of the things that I would like to say is that while I'm talking here about e-health and e-education, at IBES we've got 56 projects, and it's a fairly important part, but not all the work that we do. I think there is a propensity for governments to focus too much on health and education because they're seen as the big ticket items, and there's no doubt that broadband is going to revolutionise these two areas of our economy. But I think the focus is often unfairly weighted towards health and education. If I take me as an example, I'm a pretty healthy individual. I don't go to the doctors. I don't need a telehealth consultation. Maybe in the future I will, but right now I don't see myself doing teleconsulting because I don't need healthcare. I'm fit and healthy. I'm also at the stage of my life where, unfortunately, I don't have time to take part in formal education. I'm quite happy downloading the documents I want to read and doing a bit of researching in my free time. I'm not going to be taking an online university course or something like that. So for my portion of the population, the idea of e-health and e-education is actually not that relevant to the broadband debate. So what are the drivers? We really need to think about that. And I think the important thing I want to stress here is I do believe e-education and e-health are incredibly important, and there's no doubt that broadband is going to help these and transform these areas. But if you're talking to the community about uptaking broadband, if you only talk e-health and e-education, as some governments are, I think it's really hard to talk to the broad community as a whole. The other area, of course, is innovation, and innovation, incubation and commercialisation. And obviously, IBES, we're in our own small way trying to make a big difference in Australia. I think a really important approach is a multidisciplinary approach, and it's certainly something we're doing at IBES. There's one thing that I know about the telco industry, having worked in it for 10 years. It loves to talk to itself. We can all tell each other how wonderful our routers are, how fantastic the PABX was, and all sorts of things like that. Renee Summers at Ericsson made a really pertinent comment to me yesterday. He said the telco industry has always built for demand. It's never built without demand, and that is certainly where we are with UFB and UHB and NBN. We as an industry have to learn how to build that demand in other communities. This means we actually have to go out and talk to those other industries. That means talking not to the chief information officers or IT experts in large hospitals, which is often where you get deferred. It means we need to reach out to the movers and shakers. We need to understand their workflows and recognise what their problems are. This means talking in the health sector to the people that are delivering health. It means talking to the clinicians. In the education sector, it means talking to the educators. I think above all, we have to recognise that demand side is driven by change management. Without change management, there will be no change. We have to move from pilotitis, a term that I've stolen from the Ernie Newman's document, to widespread deployment. I couldn't agree with this comment more, which was expressed in the eHealth document. I think a place like IBES, there's no doubt pilotitis is our life. Without pilots, we will not innovate, and without pilots, we will not be here. And I think we do need people like IBES and organisations like IBES to drive that innovation. But what's really difficult is coming from a pilot into something that's really going to be long-lasting and widespread. Getting a pilot up for 20 people, 100 people, 500 people is not always difficult. Working out the business plan that takes that from a trial and pilot into something that's widespread deployed, whether it's on a state, national, community level, doesn't matter. But it's a really hard step, and there's very few examples of success. I think the other thing to recognise is that large particular sectors of our economy are cottage industries. An example of this is education. Our schools are allowed to procure for themselves. We're not thinking about economies of scale. I found out just before Christmas about a school where the history teacher was in control of rolling out 600 iPads to students. Without the best will in the world, and I'm sure this teacher was very proficient, as a history teacher, is it really his place, and is he using his time most effectively rolling out iPads to school children? What about identity management, authentication, privacy, and all those issues that we know so well in telecommunications? The federal government in Australia, I should say, are working on programs, and they've got a telehealth program in the order of 20 million, an education program in the order of 27 million to try to build large-scale trials, which are moving towards widespread deployment. But I think we certainly support those, but whether they actually result in meaningful businesses is always a difficult thing to predict. I think another key issue is literacy. We don't know what we don't know. And if you're someone living in the community who doesn't know what broadband is possible, they don't know what haptic devices could do for their industry or what video conferencing might do, how do you get those stories out so those people can innovate in their own areas of their economy? One thing we need to understand is literacy is not about learning a QWERTY keyboard, and I think many literacy programs are still stuck in the past. As I said before, iPads are a fantastic tool for the aged care community. We don't need to be teaching our older people to use QWERTY keyboards. We just need to give people examples of what they can do with broadband, get the message out there, and help people to understand what's possible. And the very last pointy end of the issue is payment. Who pays? At the moment, we're used to our broadband plans, but I think if we're talking about services as important to our society as health and education, we have to think who pays for that broadband connection. Let me give you a final example. If you're a student, say a uni student, and you're streaming an online lecture using 4 megabits per second for 1 hour, you'll use 2 gigabits of data per hour. If you think that you might be doing 10 or 20 hours a week, this is much more than most of us use on our monthly quotas in 1 week, yet we're going to be expecting students to pay. This is an awful lot of money for people that are already struggling at the seams. The same thing goes in the healthcare sector, where the people who stand to benefit the most are often the people that are missed out, who don't have the opportunity because of financial constraints or literacy constraints. So with that, I'd like to end it and say thank you very much. And if anyone wants to contact me for more information on IBES, please feel free.